I'm Ross Fleischman, and I am proud to be the scapegoat for the implementation of electronic health record for Los Angeles County's emergency departments. So, how many of you work with a significantly medically underserved patient population? I think, well, almost everyone. And how many of you wish that your electronic health record were not an obstacle to caring for that population, but an opportunity to level the playing field? All right. So in this talk, Mo and I will present some innovative things we have seen using electronic health record for patient engagement and access to care. And this is my co-presenter, Mo Saidinejad. He's trained in pediatric emergency medicine and is our director of patient experience for Harbor UCLA and serves on that committee for the county. So, in Los Angeles, we know a thing or two about underserved populations. We are by far the largest county in the country. If we were a state, we'd be number 8 just after Ohio. If we were a country, we'd be number 88 between Sweden and Portugal. We are sadly, though, only the second largest public health system in the country behind New York City. But we have 3 academic teaching hospitals, 2 of which are level 1 trauma centers, and we see about 380,000 urgent care and emergency patients per year. Now, I contend that a full 88% of our patients are medically underserved, and this includes the 23% who have absolutely no insurance, but also the 65% who are on Medi-Cal plans, which is California's implementation of Medicaid. Because while these patients do have insurance, this coverage can be very difficult to access. A typical scenario is we have a patient who can be discharged from the ED, but to get them the follow-up they need, we may have to call Medi-Cal to find out what Medi-Cal plan they're empaneled to, then find out what provider they're empaneled to. They then need to contact their provider and convince the office staff they need an urgent follow-up appointment, not one in 6 weeks. They need to see their provider, convince their provider they need an urgent specialty follow-up. The provider has to make the referral. The specialist has to approve the referral. They finally see the patient, and ultimately, they might be sent back to us at Harbor to actually have the procedure. So this would be difficult to navigate even for you or I, but this is compounded by the fact that many of our patients have limited English proficiency, half of whom speak a language other than English at home, most of whom is Spanish. So, as an electronic health record zealot, I like to believe that technology is part of the solution. And recent data shows that now 77% of American adults own smartphones. And while this is lower among certain patient populations, for example, 67% in those who earn less than $30,000 a year, and 57% in those with less than a high school education, these are still substantial rates of ownership. Interestingly, rates of ownership among blacks and Hispanics were similar to the overall. Now, this idea of using the electronic health record to drive patient engagement is not new and was incorporated in Barack Obama's 2009 HITECH Act, which promised substantial payments to hospitals that could demonstrate meaningful use of an electronic health record. So stage 1, require the electronic health record, allow the patient to, technology problem, to view the basic parts of their record, their lab results, their problem list, their immunization records, and basic information about their visit. Pretty much the same 4 to 6 page handout we dutifully prepare for every patient that often ends up in the trash before they've left the emergency department. And then stage 2 added the ability for patients and providers to message each other. Now, the clever thing about meaningful use is not only did the hospital have to have an electronic health record with these capabilities, they had to prove that actually a small number of patients, often about 5%, depending on the feature, were actually using that feature. And these features come together into a part of the record called the patient portal, which ideally can be accessed from a PC, a tablet, or a smartphone. And this is my patient portal through Kaiser. So I'm now going to turn it over to Mo, and he's going to talk about the first of our examples of things that go beyond the requirements of meaningful use in the portals.
Thanks, Ross. You guys can hear me okay? So as Ross was mentioning, patient portals are really a good way to ensure that both the phase 1 and phase 2, which means ability for the patient to actually be able to see their medical records, to be able to see their appointments, also to be able to communicate back and forth with their providers. So what if the patient portals could do even more? Because the Meaningful Use Act just basically says two-way communication. But we can leverage that patient portal to something even more. For example, imagine if you could send a patient a short video about how to take care of themselves. When the patients come to the ER, you really don't have a lot of time to educate them, and you would wish you had more opportunities. So what if you had a video specific to their medical diagnosis, and you basically put that through the portal and have them go watch it whenever it's convenient for them? So this is an example of a
Hi,
video.
I'm Dr. Christina Johns, and this is your video prescription. We're going to talk about how to take care of your child's asthma at home and what to do during an asthma flare. The best way to manage your child's asthma is to use your asthma action plan. This form is filled out by your doctor and customized to your child. An asthma action plan has 3 zones: green, yellow, and red.
This was just in the interest
Hi,
of
I'm
time,
Dr.
just
Christina
a,
Johns, and
brief version of what that video looks like. These videos, we have a whole bunch of them. They're about 2 to 3 minutes long, and they're basically tailored to the medical diagnosis of the patient, and upon discharge from the ER, we send a link to the video for them to watch, and it gives us the ability to actually track viewership, and if patients didn't watch it, we can send them a reminder. So we actually did a study to see if something like this would actually be feasible. This was a really large NIH-funded study, required us to do a randomized control design. So we ended up enrolling 16,000 patients. Half of them were randomized to a group that received a link to a message that says, "Thank you for visiting the emergency department. Hope you had a great visit." The other half would get a link that sends them to the video that was specific to their medical diagnosis. So we ended up with 8,000 patients for whom these videos were launched. And because we kind of expected that patients in different settings would have different engagement with this kind of technology, we decided to set up 3 distinctly different areas. One was in the Southeast Washington, D.C. community hospital that is mostly low-income, disadvantaged, underserved population. One was in the middle-income families in the suburbs of Washington, D.C. in Annapolis, Maryland, where the Navy school is at. And one in a very, very great income neighborhood in New York City, in an urgent care center called PM Pediatrics. So as you can see, the viewership really varied. 1 out of 8 of our lowest income group patients actually clicked and watched the video. When we looked at the middle income groups in the suburban DC, we got 1 out of 4. And when we actually launched it in the highest income group, we got 1 out of 2. And these data were the same whether the link was sent through an SMS text message on a mobile device or it was actually sent by an email. So interesting thing was that we did observe these variations, but bear in mind that even 1 out of 8 or 12% is significantly better engagement than the 1% or so that we had before. So this shows the promise for us to move forward with this, which is the next phase. We're going to actually launch this through our LA County DHS patient portal. So when a patient gets discharged from us, we actually send them the link through the portal, and then we can manage the reminders and viewership through that portal. Which brings me to a point of what is our current portal engagement in the city. So we had no idea how many of our patients are currently registering to be part of the portal. This is still relatively new. So we looked at the Los Angeles County as a whole. Of course, the areas where we have the higher income, higher educated groups, the UCLA Health System, Cedars-Sinai Hospital within that LA County's higher income group, the Kaiser Permanente system, which is notorious for being very good at communicating with their patients. As you can see, they all have about 50%, like we said, for the highest income group. In terms of engagement with the portal, that means the patient registered for the portal and at least had 1 interaction, meaning either the physician sent something to them that they clicked and opened, or they sent a question to the physician, at least 1. But sadly, when we come to our LA County population, we're back to that 1 out of 8 that we demonstrated earlier in DC. So we have work to do, and the engagement is a problem. And sadly, where Ross and I and a few of you guys work at Harbor UCLA, we're even less than 5%. So we have even more work to do. But having said that, I think patient portals, when you have enough patients on them, can be very powerful tools. And I'll give you an example of a intervention for influenza vaccination that UCLA Health started. This is kind of a busy slide. The point was only to show you that there are about 150,000 portal users in the UCLA Health system. There are about 500,000 total, which means about a quarter to a third of all UCLA patients are interacting with the portals. And this table to the right basically was an intervention 2015, 2016 by reminding all of the portal users in late August, early September, a reminder was sent, don't forget to do your seasonal flu. So if you didn't have a portal, you didn't get that reminder. If you had the portal, you did. And people would argue that, perhaps if you're a portal user, you're also more diligent and you will probably be more likely to do a flu vaccination. So it may not be effect of the portal, but effect of the patient. So this study aimed to stratify the patients kind of in two groups that are sort of even in terms of age, ethnicity, and race, and insurance types. So as you can see, those numbers are relatively, without any statistically significant observed differences, look to be lined up pretty well. And just to bring your attention to the very last row that talks about flu vaccination, that data was taken out of the EHR, shows that about 42% of those who had portal actually did the flu vaccination versus 21%. So they doubled the rate of portal, but more importantly, from 27,000 up to 61,000. So that's 40,000 people almost that were getting the influenza vaccination by being portal, who were also portal users. And like I said, because the demographics were sort of evened out on two sides, we feel like there's a really decent correlation to reminders from the portal and actually vaccination. So back to our own DHS population and portal use among them. So there is some good news. If you look at the top second row, Harbor UCLA, just in the month of March of 2018, which is a month and a half ago, 210 invitations to join the portal were sent to patients. And of these 210, 111 actually are enrolled in the portal. So that's 50%. So we went from that 11% to 50%. So it does look like overall we're doing a little bit better. And if we look at the data from 2015 all the way to now, that yellow number in the very bottom is 36,000 patients of the total 142,000 people who would have been eligible. So not only that we have 36,000 portal users in our system, but that represents 33% of the total. So that is significantly better than the 11% that we were doing before. So even within a system of ours, which is basically loaded with health disparities and problems with access to health care, we can do some great things with the portal. And I'm going to have Russ tell you a little bit more about some of the interventions that we're planning through our DHS patient portals, which is either in progress or about to be launched.
So our county portal has all the features that I would consider to be the first step beyond meaningful use. Patients can request appointments, they can request medication refills, they can get push notifications of their appointments, and they can get to it through their phone. But one of the things that I'm most proud of that goes well beyond what's often being done is that we joined the Open Notes Coalition. This is a group out of Boston that's advocating for patients to have access to their full text provider notes. So see, our portal, by the way, is fully bilingual, at least the boilerplate and design instructions are all available in English and Spanish. And so patients can actually access the text of their provider notes. And this really makes sense because meaningful use already said that we are going to give patients the raw data. We're going to give them their lab results, give them their diagnoses, so it only makes sense that they can also see the provider notes that put that information in some context. But I think the more important promise in terms of access to care and patient engagement is that if the patient can actually take their ED provider note that has the ED physician's specific recommendation on what this patient needs next in their care, can take that to the primary care physician, that will really communicate and help the primary care physician then get the patient the next step in their care that we can only start in the ED. And in terms of patient engagement and self-care, I think that patients absorb very little of what we tell them in that brief discharge encounter after a long ED visit. And for them to be able to take the note home and in the comfort of their home, possibly with the assistance of a more medically savvy or English proficient family member go over that note and at least read and understand what the next step is for them to care for themselves, I think that will go a long way to improving patient engagement. And we did one thing even more than what most Open Notes members have done. Most Open Notes hospitals are only sharing their ambulatory clinic and primary care notes. We are one of about the third that is sharing ED provider notes and inpatient discharge summaries. Now, of course, there was some provider concern about this, that, there are some ED patients who you really just don't want to have too easy access to their note. So we did create the option to mark a note as sensitive, and for that note, the patient would still have to go to medical records to get their note, as in the past. But honestly, we've been doing this for 5 months, and in 5 months of shift, I have not felt the need to invoke that option once. So Open Notes is something that we are doing in the county that UCLA is not, and I'll turn it back to Mo.
Thanks. So as you can see, this one is my own patient portal, and as you can see, I have no option to review physician notes. But the reason I wanted to show you this is because regardless of which of the patient portals you're in, you have the same capabilities. You have the same view. You can do messaging with your providers. You can see upcoming visits. You can ask for a medication refill. You can ask questions. And it looks here on that yellow clipboard one, it says, I'm due for preventing screening. I actually haven't clicked on that to see what I'm due for, but I'm supposedly due for something. But the bottom line is, this is one of the ways to address this issue of health disparities by giving patients access to the same level data regardless of the system. So my UCLA patient portal is the same as my patient's patient portal when they go to their DHS patient portal. There's nothing more sophisticated about one or the other. So that sort of levels the field. And speaking of engaging patients, there's another layer, and that is, what if instead of, or in addition to what we are giving to the patients, we were constantly getting feedback from them about how we are doing, what it is that they want. So we created this little point of service survey, which we are giving to our patients about 10 minutes before they're discharged from the hospital. As some of you guys may be familiar with those Press Ganey patient satisfaction surveys, which are really daunting. They're multi-pages, 100 and some questions, and they're mailed to the patient's house, and they tend to be biased towards the patient who didn't have a good experience, who really feels like they want to sit down and say something. But by having this as a point of service, making it so easy, only 10 questions, colorful, pretty to look at, has star system in there, we can actually get patient data that way. What if we put this in the portal so at any encounter or during any time they can sit in the waiting room, fill this out, they can do it after the visit. So we're piloting this right now for the next 3 months. It started May 1st, looking at what is the best optimum time to give this to the patients and to vet these questions a little bit more carefully and make sure that they are exactly what they want, we want them to be. And I just added this slide last night. I was just happening to sit around and wonder, hey, how are we doing with these surveys? Our patient population is about 55 to 60% Hispanic, and there are about 28 to 30% who speak very little English, and as Ross mentioned, there are half of those who speak mostly Spanish at home. But what's interesting is that of all the patients in our poll so far, the great majority of them chose to do the survey in English. We have it in English and Spanish. There's a piece of paper, one side English, one side Spanish. We give it to them with a pen and say, fill out whichever side you want. And it was interesting that more people chose to do this in English, and we're trying to wonder why that is. But this is just one of the pieces of data from what we've collected, but I just felt like I shared that with you to show all about that. So finally, just to conclude, technology is really available at everybody's fingertips, and we could really use it in order to even the field as we were talking about. It's very easy to get mobile phone streaming information, any kind of data that patients want. And not only that we can send stuff one way, but we can also get return response back, so it's really a two-way meaningful engagement. We also show that different settings have different level of engagement. This only means that we have to do more work to get certain people engaged. I don't think the idea of patient portals is bad, and I know some people are not big fan of patient portals, and some people suggest that, hey, maybe the Google personal health things are going to be the next wave of the future. But I think we are really doing well with what the patient portal has afforded us that wasn't previously available. We have to be very careful about how to engage the patients. We don't want to overburden them. We don't want to underutilize. We want to actually maybe employ some sort of machine learning and adaptive principles to see what patient requires what sort of interaction. And obviously, the more complicated patients need a little bit more information towards them than people who don't. We really need to make it patient-centered. And because Patient Portal does deal with a lot of protected health information that now is going to be available on devices and going back and forth between systems, we have to really be careful and really be responsible about maintaining the integrity and security of this information. And most portals that are designed, they have a whole infrastructure of IT support behind keeping the regulations in mind and making things really clearly safe and secure. And finally, as Open Notes does, we really need to be transparent with our patients. We need to tell the patients exactly what we wrote about them and what we talked about them. So that is one of the issues that in the past has been very difficult. Patients don't really understand what we expect of them. But transparency in the way of them being able to see what we wrote at any time they want is an important part of getting patient portals to be as useful as they can be. That's all we have, so if you have any questions, feel free.
Thank you. I think we're out of time on the podium, but if anyone wants to stay and talk, I would love to hear some ideas of what you have done with your portals or seen that you think is great that we can take back to Los Angeles.
You have a question?
My question was going to be kind of two parts. One was that I feel like the outpatient primary, like clinic providers, are getting a lot of training on how to get people started with patient portals in their clinics, and I've seen very little of that in the emergency department. So I wanted to ask what you guys think about getting people started on patient portal out of the emergency department. And the second thing I wanted to ask was, what do you think about the idea of patients following up their own results when they do have those portals? Very often I have patients that sit in the emergency department for an extra half an hour because their UA is pending or something like that. When if I can trust that patient to log in and see what their results were, so I can take an action based on that. Like, I'm going to prescribe you something, fill it. If it's it says this, so I can send you a message. Could we be saving time in the emergency department using the tools?
Right, so I can tell you about the first part of what you were asking in terms of the ED, the training we get for ED. One of the challenges with the ED is that the patient portals within the ED are set up in a way where it's harder to do the two-way communication unless you set up an entity to be responsible for receiving that information back. So the way the clinics work is that you have a certain number of patients in your panel, and that you are basically paired up in a pool of providers to the patient. So the patient has you listed as their provider. But in the emergency department, the patient gets seen by a different doctor each time they come in. So it doesn't make sense to put each one of us in a direct relationship to that patient. So the provider pools don't work for the ER. So what we need to do is have a follow-up doctor's account or some kind of a setup where they can ask the question for whoever is at that time doing it. So that is one of the challenges with that. Also, the other issue with ER is that sometimes you can be extremely busy seeing a lot of patients and you just don't have the kind of time to set up, so that training part will be more difficult. You want to talk?
On that same topic,
yeah.
Ask any of your colleagues in the outpatient setting what they think of your inbox if they have a patient portal. So the inbox, the thing that they can have a two-way communication with the patient, they spend a tremendous amount of time in the outpatient setting dealing with, and it's exceeding, time because the patients want to know, like, instead of coming in for a follow-up appointment, they're just talking to people like this portal, and it's the bane of their existence now, like their primary.
We know that disparities in health follow disparities with other resources as well. One of them is technology. So I know there are more cell phones, everybody has more cell phones, but a lot of patients we're targeting that we want to get don't know how to use them or don't know how to use them to get a portal. Is there any way that you can set up is there funding to set up a program where you could go to their, with some technology like a cheap tablet or something, teach them how to use it to get to your portal so that it does get you? Because I have a feeling a lot of people when you have these low responses in these underserved populations, is there something afraid to use the technology or they don't have it?
That's a great idea. One little step we've taken towards that is in our YouTube generation, where people are used to watching videos. We actually do have video instructions on how to use the portal. One of our colleagues at LA County is doing a study using basically text messaging. No portal, just text message. So potentially, people who are savvy enough to use text messaging, we could text message them the video that tells them how to do it. They watch the video, and that gives them the instructions on how to use the portal. But I like your idea. Mm-hmm. Maybe train them while they're sitting in the waiting room.
Yeah, even community centers, that is a good place to launch this. And again, we can have the portal actionable items be texted to them as well. So sometimes if you have a item shown on the portal that also generates a text message that says there's a portal, but when you click it in the text message, you can actually see it right there. So you're right, there's a lot of challenges, but there's also a lot of promise that's with this. Yeah. So it does help a lot with the reminders for appointments and the connection to the medical home to get people to be more connected with their primary care doctor, which hopefully means less ER visit. The challenge of, we always thought about the challenge of what if the patient can figure out whether what they have is an emergency or not. And I think that's scary part of that is that it's very hard to make the patient say, okay, I have this tool that tells me I don't need to go to ER. Then we were afraid that some patients may overutilize that, and when they should be coming to the ER, that they decide I'm fine. So even as something simple as, hey, this is your fever chart. If your child just has a fever, don't come to the ER, just give them some Motrin. But we never know what that fever is from. So there are challenges with that as well. So we have to be a little bit careful. But absolutely, we have shown that office visit no-shows have been decreased just from that first few months worth of the use of the portal. Again, the numbers are not great at the moment, so we can't make major claims, but the direction is positive. That's what we would say.
Thank you.
Okay, thanks so much, guys. Really appreciate it.